Dear colleague, welcome to this lecture on the history of stereotactic neurosurgery for movement disorders. In order to fully understand the development of stereotactic neurosurgery for movement disorders, you need to understand the history of psychosurgery. So make sure that you have watched the lecture on this topic, since I will not repeat the details here. We will also disregard the oldest neurosurgical history, since there is not really much of interest here regarding movement disorders, in contrast to the history of psychiatric neurosurgery. However, nothing comes from nothing, and there is no history without a prehistory. Some historians hold that history is just one damned thing after another, but these things may be arranged in various ways, and seen from different perspectives. And the history I will present here will attempt to demonstrate the evolution of the field, but also to show how much of what we are doing today was already done 60 years ago. Further, when we study history, we often assume an orderly progression, but much of this progression is only clear when seen retrospectively, and owes much more to serendipity and chance than we generally assume. And if you would like to have more details, then I can recommend this recent paper by Marwan Haris, from whom I have borrowed much of my material. So, let us start our journey and take a short look at what happened before Ben Abid. The development of more modern theories regarding the brain can be said to start with the publication of De Humani Corporis Fabrica in 1543 by Vesalius. We then see a rapid development, especially during the 19th century, regarding human anatomy, comparative anatomy, histology and pathology, and for our topic, the discovery of electricity is of certain interest, and this field developed rapidly during the 18th century. This was also the case regarding bioelectricity, and experiments on humans were soon being performed, dead as well as living. Electrical stimulation of the brain on living animals was done as early as 1809, and the first experiments on alive humans around 1870. Even though detailed mappings were done in this manner by Ferrier and others, the most important technique for mapping of the human brain was cerebral localization, where you look at the symptoms of the patients and later, at autopsy, correlate these with changes in various areas of the brain. Parallel to this, we see a development of surgery, with a growing awareness of how traumatic brain injuries and hemorrhages causes symptoms. Previously, the indication for trepanation had often been to remove hemorrhages, which were believed to cause the symptoms due to a presumed toxicity of the blood, or in some non-traumatic cases, to exhale presumed toxic vapors of other substances. However, now it was getting clear that the symptoms were often caused by hemorrhages, causing a pressure on the brain, and that the indication for trepanation was to relieve this pressure. This pressure hypothesis was then extended to other conditions and came to include also trepanations for psychiatric conditions, epilepsy, and even for movement disorders, even if very rarely performed. And with all these advances, we come to the birth of modern neurosurgery in the end of the 19th century, when William McEwan, Victor Horsley, and later Harvey Cushing introduced cerebral localization, general anesthesia, antisepsis, and new techniques making intracerebral procedures possible. And we then see the pressure hypothesis being substituted more with the hypothesis of excitable areas. And the next step was the removal of cortical areas for epilepsy, psychiatric conditions, and movement disorders, so-called excitable areas. And the first open intracerebral procedure for movement disorders was performed already in 1890 by Victor Horsley. And here we see operation sketches of the excised precentral gyrus and postoperative photos in a patient with athertosis in the left arm. And similar procedures were to be done by others during the coming decades, and as late as 1939, Busey stated that neurosurgical alleviation of tremor was dependent upon production of paralysis or damage to the pyramidal tract or corticospinal pathways. and the basal ganglia were, according to Walter Dandy, no man's land. One of the pioneers who ventured deeper into the brain was Russell Myers, who extirpated 2/3 of the head of the chordate through an anterior approach, and the origination of this idea reportedly arose from a chance observation by Broder, who during a frontal lobectomy carried out the extirpation far into the chordate nucleus in a patient with Parkinsonian features. And when the patient awoke, the shaking had stopped. The procedure he developed started with removal of the head of the chordate, but over time he would gradually move further down until he eventually operated on the pallidum and the ansa lenticularis. And Meyer's work inspired Fenelon and Guillot to coagulate the ansa lenticularis. Then we have Earl Walker, who in 1949 developed the mesencephalic pedunculotomy for the treatment of hemiballismus, and this procedure was also extended to the treatment of Parkinson's disease. Irving Cooper, while attempting a pedunculotomy on a PD patient, occluded by mistake the anterior choroidal artery. He aborted surgery before the pedunculotomy was done, and the patient awoke with no neurosurgical deficit and without tremor. And thus a new surgical procedure was born, and pathological studies demonstrated that ligation of the choroidal artery resulted in a degeneration in the pallidum. Another open procedure, but for psychiatric disorders, was the lobotomy, and this is of certain interest for our topic today. This procedure was developed in the 30s and embraced with much enthusiasm by some practitioners. However, even if beneficial results were seen in some patients, it was evident that this came at an often high cost. The side effects of lobotomy were well known in the medical community since the first beginning, and due to the side effects of lobotomy we see a development towards more selective and refined procedures. There had been earlier attempts of framing the brain, but the first to introduce stereotactic functional procedures in humans were Spiegel and Weisses in 1947. Stereotactic functional neurosurgery was introduced with the specific intent of reducing the side effects of lobotomy. The first procedure was anterior thalamotomy for psychiatric disorders based on the theories of Walter Freeman. Stereotactic lesional procedures were first used for psychiatric disorders, but it never attained any widespread popularity, but it came to revolutionize the treatment of movement disorders. Within short, a large number of different stereotactic frames had been developed, and it seems as if there was no decent neurosurgeon who did not have his own frame. And frameless surgery is, as you see in these three systems, nothing new, but were developed already during the early days of stereotactic neurosurgery. And new atlases were developed, and within short, the anterior and posterior commissures of the third ventricle were established as the most important landmarks. The history of stereotactic functional neurosurgery is to a large extent the history of imaging. Already in 1897, 1 year after Röntgen introduced Röntgen, the first stereotactic frame was constructed and used by Contremolin in Paris. The ventriculography, introduced by Dandy in 1918, became the foundation for stereotactic functional neurosurgery when it was introduced in 1947 by Spiegel and Weisses, and for the coming decades. The introduction of CT had a great impact, and the introduction of MRI in 1977 were to completely change our field. But these are recent events, and let us stay with the ventriculography for the moment. So, the identification of the different brain targets were done using these atlases and ventriculographies, where the anterior and posterior commissures could be identified. And it is of interest to note that despite the later introduction of the CT and then of the MRI, Ben Abid continued to rely on the ventriculography for his whole career, and it is still being used in some places. Various modes of intraoperative testing for verification of the location before lesioning were developed, such as electrical macrostimulation, including high-frequency stimulation, impedance recording, microelectrode recording, and heating of the electrode to produce reversible lesions. and stereotactic lesions were performed with various techniques. Radiofrequency lesions were to become the golden standard, but other techniques included mechanical lesions with a leucotome or inflatable balloons, cryosurgery, injections of alcohol and various other substances, and implantation of radioactive yttrium seeds. And Lars Leksell started in the 50s with stereotactic radiation, which led to the development of the gamma knife. There is a lot of interest in focused ultrasound today, but this was used early on by, among others, Russell Myers for movement disorders and by Petter Aron Lindström for psychosurgery. A vast number of different techniques and electrodes were used to produce radiofrequency lesions, and even electrodes for directional intraoperative stimulation and lesioning were developed as seen here. Already from the first years, some surgeons would use various methods such as injections of contrast to verify with immediate postoperative imaging that they had reached the desired target. And based on the atlas coordinates, many studies regarding optimal targets and such were published, but evaluation of the exact size and location of the lesions could of course only be done in autopsy studies, and these were often of high importance, as we shall see regarding, for example, the thalamotomy. Tractography-based targeting in the individual patient was of course not possible, but different pathways and fiber bundles of interest were well known, and anatomical studies were performed also with consideration to these. To take a few examples, so were the discussion in the 60s regarding the optimal target for tremor very similar to today's discussion, even if we have access to MRI-based tractography. And the first thalamic target in the thalamus was identified based on Wallerian degeneration following lobotomies. So, we then come to indications and brain targets, and the first patients to be operated with a stereotactic lesion was a patient with Huntington's disease. This was done by Spiegel and Weises, and they made a combination of two lesions. One in their target for psychiatric disorders, the dorsomedial nucleus of the thalamus, since it had been noticed that the patient's symptoms became worse when he was agitated. But they combined this with a lesion in the pallidum, and thus the stereotactic pallidotomy was born. However, the pioneer of pallidotomy for Parkinson's disease was actually Hirotaro Narabayashi, who made procaine oil injections into this target, which was very anterior in the pallidum, as we see here. And then Cooper and everyone else started making pallidotomies for Parkinson's disease, but the pallidotomy of that era was most often not the same as used today. Some surgeons targeted the GPE, some made combinations of the GPE and GPI, and all of them were in the anterior and superior part of the GPI, with the exception of Lars Leksell, who started in the same area, but gradually, based on the effects, moved his target deeper and to the posterior part of the GPI, as we will discuss later. Then in 1954, Hassler, based on his anatomical investigations, introduced the ventrolateral thalamotomy, and this soon became the procedure of choice due to its better effect on tremor. But the thalamotomy was popularized in the USA by Irving Cooper. He performed a pallidotomy in a patient with an excellent effect on tremor. Later, when the patient died in a car accident, the autopsy revealed that the lesion was in fact in the ventrolateral thalamus, and hence this became his target. And now virtually everyone changed their primary target to the ventrolateral thalamus, but there was a considerable variation between different surgeons in the preferred target, as we see here in Leitinen's review. And perhaps that's natural considering at how many locations tremor can be alleviated, as documented by Gillingham. The VIM in the posterior part of the ventrolateral thalamus was introduced as a specific target by Denise Alpfessar, working with Guillot. Alpfessar pioneered micro-recording in Parkinson's disease, and with Guillot's frame with a trajectory from posterior to anterior, much of the ventrolateral thalamus and even the pallidum could be analyzed with one or a few trajectories. And the thalamotomy naturally resulted in an exploration of the underlying subthalamic area with the introduction of a number of new procedures. As today, numerous different brain targets were investigated for a large number of different conditions, even if only a few were common. But one of the subthalamic targets became commonly used, and this was the subthalamotomy in the PSA, the posterior subthalamic area, introduced by Wertheimer in 1960. And please note that even if many different areas were lesioned in the subthalamic area, lesions were never intentionally made in the subthalamic nucleus itself before the arrival of STN-TBS. And during the following years, thousands of patients were operated with the subthalamotomies in the PSA by Leitinen, Mundinger, Hodar, and others. And when we read the literature from this era, it is important to realize that the term thalamotomy was often used to encompass also the subthalamotomies, and many used combinations of these two procedures. So, stereotactic functional neurosurgery was thriving, and then came L-dopa. And here we see the dramatic effect of the introduction of L-dopa exemplified by the situation in one single hospital. In 1967, 110 procedures were done for Parkinson's disease, and 4 years later, this field was practically dead. And even if the odd procedure was still being done in some hospitals for movement disorders, very few operations were to be performed for Parkinson's disease during the following 2 decades. And this lasted until the reintroduction of Lars Leksells posteroventral palidotomy in Umeå in 1992 by Lauri Leitinen. It is here important to remember that the palidotomy of Leksell was not a palidotomy typically performed during the lesional era, but much more posterior and deeper. Unfortunately, Leksell had published his results of palidotomy in 81 patients in 1960, when the focus was on thalamotomies, and further in Acta Neurologica Scandinavica, which is not the most well-read journal, and hence his findings did not at the time receive much attention. However, Leitinen read the paper and consulted Leksell and started his study of 38 patients in 1985, with the help of a young neurosurgeon whom some of you might know. The preliminary results were presented at the first Arctic Stereotactic meeting in Umeå in June 1986 and published in 1992. And now the posteroventral palidotomy of Leksell was met with a far greater interest and enthusiasm, and the procedure started to spread once again around the world. And one important reason for this was that Leitinen was not really treating the same disease as during the lesional era. During the lesional era, surgery for Parkinson's disease was more or less synonymous with surgery for Parkinsonian tremor, but Leitinen treated patients with what has been called the post-levodopa phenotype of Parkinson's disease, with also on-off phenomenon, dyskinesia, and dystonic symptoms. And Leitinen could now demonstrate that the palidotomy was not only efficient on the original Parkinsonian symptoms, but also for these L-dopa-induced side effects. And please note also that this was before the Albin de Long model, and that the target was identified by an analysis and gradual adaptation of the relation between the location of the lesion and the outcome. The second part of this renaissance, and from our perspective the more important, was of course the introduction of modern deep brain stimulation. Deep brain stimulation was introduced already in 1948, but initially made its mark only in the field of psychiatric neurosurgery, with pioneers such as Lawrence Poole, José Delgado, Wilhelm Sem Jacobsen, Natalia Petrovna Bechterera, and Robert Heath. And an important limitation during the early era was, of course, the technology. But in 1973, a new pacemaker had been developed, and the first DBS procedure for pain was performed. Within a few years, the first pioneers applied the new technology also to movement disorders, and in the 80s a fully implantable system was developed. In 1977, Fritz Mundinger became the first to use chronic DBS for movement disorders, and already in 1980 Bryce and McClellan presented 2 patients implanted with a closed-loop system where sensing of tremor activated high-frequency stimulation in the zona incerta. In 1983, Orlando Andy concluded that the VIM and other thalamic and subthalamic areas were the optimum site for elevation of tremor. And we then come to the second step in the renaissance for stereotactic functional neurosurgery, the introduction of modern VIM DBS by Ben Abid and the Grenoble group in 1987. Here the concept of high-frequency stimulation was defined. DBS was previously experimental, and it marks the birth of DBS as a therapeutical option for movement disorders. However, it would be possible to see that paper also at the last of the early studies on DBS, or perhaps even more correct, as the transition between early and modern DBS, since interest started to grow only after the introduction of a new target, the subthalamic nucleus, in 1993. The subthalamic nucleus, the STN, had been avoided as a target in functional neurosurgery during the lesional era for fear of hemibalism. In the early 90s, Hagai Bergman, then Tipo Assis and collaborators performed lesions of the STN and demonstrated improvement of Parkinsonian signs in the MPTP model of Parkinson's disease. And Ben Assis used high-frequency stimulation of the STN in the MPTP monkey. With the first implantation in the STN in humans, Alim Benabid and Pierre Pollock and the Grenoble group set the stage for a new era in the surgical treatment of Parkinson's disease. STN-DBS proved to be a more efficient target than the GPI, especially since bilateral paladotomies were seldom used. And if we look at the number of publications regarding lesional surgery in DBS during the following years, we see how the number of publications regarding lesional procedures increased some years after the reintroduction of paladotomies by Leiten in 1992. In the same manner, the introduction of VIM DBS did not have any immediate significant effect on the number of publications, but these increased a few years after the introduction of STN DBS. Thus, the introduction of DBS in combination with a new target, the STN, was the most important step in this development. And in the same way as the academic interest for DBS surpassed the interest for lesions around the millennial shift, so STN DBS replaced the paladotomies in clinical practice. So, let us take a short look at what happened after Benabid. Parallel DBS was inaugurated by Sean Siegfried in Zurich in the early 90s as an alternative to paladotomy for Parkinson's disease. Parallel DBS, however, even if commonly used in the USA for Parkinson's disease, became more important only later in the treatment of dystonia. And parallel DBS for dystonia was pioneered in the late 90s by Joachim Kraus, Andrés Lozano, and by Philippe Coub in Montpellier. And the same happened in the VIM, where at the millennial shift Rick Schurman demonstrated DBS to be a better option than lesions, especially when performed bilaterally, and DBS has today mainly replaced lesions, even if we are now seeing a revival for thalamotomies with focused ultrasound. DBS is now a well-established procedure in STN, GPI and VIM DBS for movement disorders, Parkinson's disease, dystonia and essential tremor. So, we have a new target compared to the lesional era, the STN, but initially the posterior subthalamic area that was commonly used during the lesional era was not a target for DBS, but was practically forgotten. But I believe that we are now seeing a renaissance also for the PSA as a target for DBS, and it seems as if also this target will be resurrected from the dead and become a part of modern DBS. But with this, we have actually entered the present era, and it is hence time for me to end this historical presentation. If you would like to have more information on this subject, then please visit the Stereotactic Academy at stereotactic.org. Thank you.